Okay, we're going to get started and let's let folks roll in as they do. But hi, everyone. Again, this is Jayla. My name is Jayla. I use she, her pronouns, and I am with the National LGBT Cancer Network. It's so exciting to see all of you here. I see a lot of familiar names, like people that have been involved with cancer leaders like us for a while, people that are new. So if you're new, welcome. It's great to have you here. I don't know how you found us, but I'm glad that you're in this room. So a few things that we're going to go over today, and we'll start off doing some introductions. If you're new to us, I'll go over the National LGBT Cancer Network. We'll go over Cancer Leaders Like Us, who is hosting this wonderful event. We'll get into our panel discussion, and I'll get a chance to introduce our amazing panel shortly, and then we'll close out with announcements. So I won't keep you all longer than an hour, and if a few other housekeeping things, like I said, go ahead and introduce yourself in the chat. If you see someone you know, go ahead and say hello in there. And then also, if any questions that you have come up throughout the duration of this program, go ahead and utilize the Q&A feature that we have. It should be in the bottom navigation bar of your Zoom. And if you have any questions directly, you can go ahead and ask either Shai or myself. And then, yeah, we'll just jump right in. Like I said, my name is Jayla. I use she, her pronouns. I'm the project manager for the Cancer Leaders Like Us program. And then I'll pass it over to Shai, who is also part of this amazing program team.
Hi, everyone. My name is Shai Silad. I'm a senior project associate here at the Cancer Leaders Like Us project. And yeah, it's great to be here.
And then you can go ahead. Okay, so for those of you, I'm hoping that all of you know a little bit about our organization, the National LGBT Cancer Network. But for those of you who don't, we are an organization that has three main priorities: educating, advocating, and training. Our education is primarily for communities, the LGBTQ population, about increased cancer risk and the importance of screenings, and care. Advocating, we do a lot of engagement with mainstream cancer organizations, the media and research on issues related to our health. So that can include tobacco, HPV screening, etc. We have a lot of resources on our website if you all want to go check them out. We have an expansive resource library, as well as trainings that we've done that you can check out on our website. And then that kind of leads to number three. We do public health training with health organizations, community organizations, so that our providers can be more welcoming to our community. And if you want to go ahead to the next slide. Cancer Leaders Like Us is a program within the National LGBT Cancer Network, and we call Cancer Leaders Like Us CLLU for short. So if you hear me refer to it as CLLU, you know what I'm talking about. CLLU is a program for our emerging leaders that are interested in the public health space. And those emerging leaders usually identify as LGBTQIA+ and or BIPOC. And really the main reason that we have CLLU is to create a community to support and resource our emerging leaders. So we do this through things like having career talks and events like we're having today, so that we can educate our emerging leaders about what are some of the opportunities career-wise that they can go into. I know Cancer Leaders Like Us, the name is probably misleading. It's not only for people that are interested in cancer-specific careers. Obviously, we want to get people there so that we have a more representative field. However, it's open to anyone that is interested in public health and health equity across the board. So like I said, we do career talks. We also do skill building. We have networking opportunities and internships. This program that we're having today, you can go to the next slide, Shai, is a program of our Student Advisory Committee. This is the first time, so our student advisory committee started working together in, I believe, May, and they worked all the way into the summer, informing our programming, discussing a lot of the other health issues that are kind of personal to them in their communities. And this is a very national network. As you see, some of the names of the students that are participating and kind of where they're from, they come from all over. And this reads from right to left. And then we have India Smith, who is going to be our moderator for today's event, and is also a very active member on our student advisory committee. She is a graduate student and currently at Bowie State, hoping to pursue medical school. I'm not saying hoping, will be pursuing medical school shortly. She holds a Bachelor's of Science in Human Performance from Howard University with a minor in chemistry. And outside, not only is she a committed member of our student advisory committee, but she also is dedicated to addressing health disparities and promoting health equity, and does that through her internship at the state as a state health policy through ACT. She's a medical scribe, a mental health aid certified advocate, and is just doing a lot of amazing work. I think I first met India last year around this time, even before we had a student advisory committee. And so she's going to be the one that's going to be moderating our panel today. So you'll get a chance to see her soon. And if you want to go to the next slide. And then without further ado, I want to get right into this discussion. We don't have a lot of time. And like I said, time flies when you're having fun. I know all of us are here because we're kind of aligned in this work, but I want to introduce you all our panel, which was brought to you all by our student advisory committee who organized this lovely event. So first up, we have Dr. Katie Batza, who is a historian specializing in late 20th century US history and focusing specifically on sexuality, health, and politics. Katie received their PhD in US history from the University of Illinois at Chicago and is the author of Before AIDS, which explores the gay health activism before the AIDS epidemic. So is here today to kind of bring that historical lens to a lot of the public health conversations that we'll be having. Next, we have John Fulton, who is a clinical associate professor at Brown University. We are Brown University strong here, and I don't know if that's because we have some alum that are in our staff and on our board. And so, yeah, Brown University is representing strong. But John is coming with a background in behavioral and social sciences, is currently doing research on HIV and a lot of the public health efforts in that department, and is formerly the chief health program evaluator at the Rhode Island Department of Health. Then we have Dr. Omar, who is the Director of Health Services and Research at the doctoral program at Brown University. So another Brown person, and is coming from the expertise of health economics, behavioral systems initiatives, health systems reform, and also has extensive HIV prevention and treatment research experience. And then last but not least, we have Lorraine Reitzel, who is currently a professor and deputy chair of health disparities research at the University of Texas MD Anderson Cancer Center. The research historically focuses on the social determinants of cancer and cancer risk behaviors. And she's also a fellow of the American Academy of Health Behavior and Society for Research on Nicotine and Tobacco. So has some background in that department as well. That is literally just the tip of the iceberg with all of our amazing folks that are on our panel and our moderator. They will share a little bit more about the things that they're doing in this conversation. But without further ado, I will pass it on to India, who is going to be moderating this event. Go ahead, India.
Okay. I wanted to start off again by saying thank you guys for coming to talk to us. The first question I have is, what is the most urgent health equity challenge that you are currently dedicated to resolving? And what are some key aspects of this issue that make it particularly pressing? Anyone can answer.
I can go ahead and go. I think for me, the biggest issue among the groups that I study are access to trans healthcare, particularly for trans-identified youth. I think we're all pretty familiar with how this kind of plays out across the national political landscape, but I think the health implications are severe. And I know we don't necessarily correlate cancer with this kind of care, but I think setting the precedence of making doctors' offices unwelcoming spaces does have health implications that can lead to cancer later on for our trans and queer identified youth. So that's what concerns me the most, and that's certainly the thing I'm kind of most active around right now. Thank you.
I'm involved in a study that's now beginning to focus on return to care amongst HIV-infected persons. In the state of Rhode Island, we have between 300 and 400 persons, residents, HIV-infected, who have fallen out of care, in part because of some of the reasons that Katie has just enumerated. Care is not particularly fun place for them to be. It is not particularly welcoming place for them to be. They are anxious. Some are anxious about presenting themselves and answering a million questions and so on and so forth. Difficult. We'll be talking, I'm sure, about intersectionalities later, but very, very, very difficult to a very extremely diverse group. And therefore, from a public health perspective, where we tend to abstract everything, we tend to lump everyone. Very, very difficult, very, very difficult group to access, to invite back to care, and to support when they come back to care.
Anyone else before I go to the next question?
Hi, my name is Lorraine. My pronouns are she, her, hers, and I work in the area of tobacco control. And, you know, you may think, are people still smoking? But the reality is, yes, people are still smoking. The general US population, the smoking rate is about 12%, but smoking and other tobacco use is becoming increasingly concentrated among various marginalized and minoritized groups right now in our nation. And its response, it's the #1 leading cause of death and disability, as it has been for decades. And so, yes, this is an ongoing issue, and this is an ongoing issue within the sexual and gender minority community as well, where tobacco industry advertises at pride parades and does a lot of other things to market to this community. And part of the reason why I think that this is such a pressing issue, aside from its association with disease and death, is that it's a social justice issue. If you look at the ways in which the tobacco industry has marketed to and talked about various populations, including sexual and gender minorities, you will see that they think very little of the people that they're marketing to. And I think a great example of this is R.J. Reynolds had a program called Project Scum, which stood for subculture urban marketing, that was targeted towards reaching the sexual and gender minority population and individuals experiencing homelessness. And that tells you a little bit about what the tobacco industry thinks about these groups that they're marketing to.
The most pressing issue right now for health equity challenge for me has been something that I've been working on still for almost 20 years and still very present, which is access to treatment and prevention for HIV at the global health level. So the UNAIDS goals are 95, 95, 95. So 95% of those living with HIV should know their status. Of those, 95 should have access to treatment, to antiretroviral treatment, which is life-saving. And of those, 95 should be virally suppressed. So if I'm HIV positive, I take the pill every day, the virus replication goes down, there's almost virtually no virus, so I'm undetectable. If I'm undetectable, then I'm untransmissible, right? U equals U. And that means that I will not be capable of passing the virus on to sex partners or vertical transmission from mom to child during lactating months. So that's very important. And yet we're not there. The latest numbers that I've seen is that we're around 86, 76, 71. And the last one is, a big increase from where we used to be. We used to be around 40. So viral suppression, only about 40% of those who were taking antiretroviral treatment. Now that has gotten to around 70%, which is great, but still not excellent. So how do we make sure that people take their pill every day? It may seem simple for some of us, but it is very complex. And so a lot of the work that I do is economic-based interventions to make sure that everybody has good adherence, so that they can preserve their life, their health, their livelihood, and not pass on the virus to others.
Thank you. Okay, so you guys are all so accomplished in your field of work. And so I wanted to know if you guys could share some examples of successful initiatives or strategies, either on a local, national, or regional scale that has effectively tackled health disparities within your area of focus. If you guys could give like maybe some key elements to that success and approaches that could be adapted or replicated in other contexts. Whoever would like to go first.
I'd like to just, in the realm of cancer control, certainly over the past 30 years, we've had excellent control of both breast cancer and cervical cancer. We've done a lot of work on women's cancer screening. What has worked is cost. Back to Omar. What has worked is reducing the cost of mammography, of OB/GYN exams, pap tests, so on and so forth, and treatment following to zero via several techniques, but mostly federal funding from about 1995 on, one way or another. Now supplemented with ACA type funds, but also complicated by ACA funds because it's ACA has tended to particularize. When people do not have financial backing, financial access to care, it just does not happen.
Thank you. Did anyone else want to answer?
Sure, I'll mention, tobacco, the area of tobacco, it's a good example of where we've put into place some population level interventions that have been successful in reducing tobacco use among the population in general. So these are things like putting heightening taxes on cigarette purchases and other public health other public health interventions like that. However, unfortunately, those successful interventions have had this unfortunate effect of creating subpopulations of individuals that are unable to quit without a lot more tailored intervention and attention. And so now smoking is concentrated among individuals of lower socioeconomic status and among other groups to whom the tobacco industry markets and keeps very, very addicted through their products. And so what we work to do, and I'm not just saying this because my funder happens to be on this call, but my funder is on this call. We like to think that the interventions that we do through our CPRIT funding is one way to tackle health disparities among these groups. And so we work with trusted healthcare organizations where these individuals are already being seen, whether it's behavioral health clinics, whether it's LGBT community centers, substance use treatment clinics, and we work with them in order to train their providers to deliver tobacco screenings and tobacco interventions. And so I think that some of the most important elements in tackling these health equity challenges are to partner with organizations that are trusted and that work with, that actually have the reach to a large group of individuals that you're trying to address. And then moreover, to design interventions that are sustainable within those settings so that when you, the person from the university, kind of backs up and backs away and or the funding ends, the intervention continues for that group into the future.
I'll kind of follow up on that and say, in my work, I've studied a lot of kind of the history of how LGBT community health centers came into being, largely because LGBTQ folks felt deeply ostracized and pathologized by mainstream medicine. And while that isn't the case to the same extent that it was in the 1970s and 1980s, I would say that one of the big interventions that I push for and that I hope others kind of embrace more is really trying to get LGBTQ healthcare into med school education, making sure that doctors who want to be LGBTQ welcoming and knowledgeable have easy ways of doing that, and that we get away from the really problematic practice of just slapping a rainbow sticker on a door and calling yourself LGBTQ knowledgeable and friendly as a practitioner. I think that does nothing but exacerbate health inequities and long-term problems. So, yeah.
I will pick up the cue from John on costs and bring it back to HIV care at the global health level. So prior to going to grad school, I worked for 2 years in Ethiopia, and I started doing research on the costs and the availability, the budgets for HIV prevention, and it was pitiful. It was 50 cents to $1 in many countries. Certainly that was the case in Ethiopia. And as you may remember, antiretroviral treatment was available already in the US since 1996, and certainly in Europe by the late 90s, early 2000s, but it was about $10,000 per person per year. So to have that in Ethiopia was virtually impossible. And my personal professional motto has been sort of, how do we get the best health for the most people for the least cost? So obviously, to get the best health for the most people, we really needed those medicines in sub-Saharan Africa really quickly. And there was a big push for prices to come down. So Treatment Action Campaign in South Africa and Doctors Without Borders and Clinton Foundation and many others really push hard to really have those pharmaceutical prices come down, to the point now that now 20 years later, you can have antiretroviral treatments in countries like Kenya and Ethiopia and for about $45 per person per year. It's amazing, how much the prices have come down. And of course, once you have them at that price, then, they are more affordable. So how can that be translated to other contexts? I think is very clear, right? As mentioned, for HPV and other types of cancers, where the vaccines may be very expensive. If they're very expensive, they're going to be out of reach in many countries. And so if there is push, if there is lobbying, if there is creative health systems approaches to make sure that those prices are affordable, then of course you can get more easily, the best health for the most people for the least cost.
Thank you. Okay, so the next question is a little more loaded than the previous two. In today's dynamic and interconnected world, why do you believe it's crucial to approach health equity through an intersectional lens? How does considering the intersectionality of various factors enhance your understanding of and ability to address health disparities effectively? And could you also provide some concrete examples of how this intersectional approach has made a difference in your work?
So one of the research projects that I'm working on right now is I'm working with a team of applied behavioral biologists, some MDs and whatnot, building off of a survey that was developed several years ago and that we keep updating about the experiences of people with various forms of disabilities who also identify as LGBTQ. And when I joined the team, we started doing follow-ups to these surveys with small interviews, short interviews. And what we kept finding again and again was that folks who had more oppressed identities overlapping, the the poorer their health outcomes were, not surprisingly. However, if we start thinking about interventions that access that person that is the kind of experiencing the greatest number of challenges, and design a program that solves their problems and increases their access to healthcare, we can actually improve everyone's healthcare access. So, for example, if we're looking at a gender non-conforming person who is physically disabled and lives in a low-income part of town and is Black, then that person is ostracized from the mainstream medical system in lots of different ways. They can't access it. Transportation is really difficult. Their provider doesn't understand their needs, or buildings are inaccessible. All of these different things, right? Let alone the cost of healthcare. So if we start chipping away at one thing after another, it'll take forever. Whereas if we imagine kind of a health response that addresses all of these issues at once, what will it take to get that person to a doctor to get the care that they need? Then other people who are not experiencing quite as many things will also be able to.
I'd like to build on what Katie just said. Once we get them to the doctor, what's critical is that we get a trusted relationship between provider and patient. What's critical for that is continuity of care. Ultimately, medical care is totally, absolutely intersectional. Why? Because it focuses on a patient. Medical care focuses on a patient. And for that to work, you need trust between patient and provider. And you need that relationship to continue over time, especially with chronic illnesses like HIV infection, any form of cancer we're talking about. Someone mentioned HPV, and by the way, it's biologically intersectional with cancer for reasons that are immediately obvious. Very continuity of care, very, very important. So as opposed to the episodic care that a lot of people get by going to urgent care units, emergency departments, and so on and so forth. It just doesn't work. Now let me briefly, just very, very quickly, intersectionality with regard to, again, persons who fall out of care, HIV persons who fall out of care. We have groups of individuals, and again, I don't want to use any broad strokes here because I believe in the use of let's call it an intersectionality kind of thinking here. And we have persons who have untreated mental illness, who are homeless, who are HIV infected, and maybe LGBTQ, maybe a member of a racial minority, and so on and so forth. Very, very combinations that I think public health doesn't know what to do with it. So from a public health perspective.
If I can jump back in, and I just think we also need to think structurally about the way that we do public health and medicine more broadly. And I'm saying this as someone who's neither in medicine nor public health, so I apologize if I'm overstepping. But it seems like from my perspective and the research that I've done, that medicine is largely siloed into individual things. And so for an individual patient who has many different identities, many different health needs, there's a lot of code switching that can happen depending on where you are. If you're going to see your mental health clinician, you'll talk about your mental health needs. But if you're going to your oncologist, you might not mention that because you don't want the stigma attached with that. If you're going to your oncologist, you're not going to mention that you're LGBTQ, whereas that might be the thing that you talk to the most when you're going to your, I don't know, proctologist or whatever, right? So all of these different kind of silos are designed to supposedly see the whole person. But what ultimately happens is, I think, is that because of the stigma associated with various identities and the feeling of not being safe in these various locations, is that people really don't present their full selves to those in those situations. And so we need to rethink how we organize kind of holistic care and how we make it acceptable and accessible for everyone, whoever they are. One of the shocking findings was just the extent to which so many folks really don't come out to their doctors as disabled in different ways, even though it's a medical disability. And or they don't also come out as LGBTQ, even in places where you would think that it would be kind of more acceptable. So yeah, I think we need to like flip the coin a little bit, and it's not just about reaching the population, but I think it's about reaching them with what the system is and how it's flawed.
Right, and I think that understanding the dynamics from intersectionalities can help to inform the treatment approach, right? So you're talking about various stigmas, various discrimination that results in significant stress that is experienced by these groups that can be, proportionate to the number of intersectionalities they identify with, which then could be the mechanism that you build an intervention around. I mean, I know in smoking, having this stress, experiencing discrimination is absolutely a trigger to use tobacco, to increase the urge to smoke tobacco. And so it's how you really understand the group that you're working with. And one of the ways in which we use that information is in tailoring health promotion messages and materials. You have to understand your population and the intersectionalities within it in order to create material that speaks to the diversity within any respective subpopulation, including LGBTQ, so that you're talking the right stuff to the right people and you're making sense.
That translates to research as well. For example, we have research, say in Mexico, right, with men at very high risk of HIV acquisition because they're in the commercial sex trade, and so we have a project in Mexico City to provide PrEP, which is pre-exposure prophylaxis, and we have economic incentives for them to adhere to PrEP, which is again an antiretroviral that you take every day, and we measure the hair to look at the antiretroviral accumulated in the hair, and we provide incentives based on that. And we actually finished this R34 pilot trial, and the results are different, right? When we looked at whether they self-identify as gay or not. If they say they are a street-based sex worker versus internet escort, it's different if they are from Mexico City versus from other parts of city of the country that they've come into the city. And so, there's heterogeneity of the effect. The same happens in the US. We have a project where we analyze the effect of the Medicaid prescription caps using all of the claims for Medicaid. And we have this project is a narrow one. We've been looking at the data, the claims, millions of claims for hundreds of thousands of people. And what we see is like these effects of the Medicaid prescription caps, which some states try to save money by saying, you cannot have more than, say, 3, 4, 5 medicines. And so, it's different if we look at men and women. It's different if we look at trans versus non-trans population. It's different if we look at younger versus older populations. It's different if we look at persons just living with HIV versus living with HIV and other chronic or non-communicable diseases is different, of course, by state, with and without cap, and different also by time. So this idea of intersectionality is very applicable also for the research analysis and how you present your results and how you dissect the data.
Thank you. Oh, you can go. I'm sorry.
Just one, there's an issue also, a reimbursement issue about what the insurance and various third-party payers consider voluntary versus necessary procedures and medications. Voluntary versus necessary. For example, is PrEP voluntary or necessary? And the PrEP costs can be considerable.
Thank you. So my next question is, based on your years of experience in research, what policy recommendations do you propose within your focus area to bridge the gap in healthcare access and outcomes, particularly amongst vulnerable populations?
That's a great question. You saw my thinking face for a second there. Sorry. I mean, I think I'm going to stick with improving education both within medical school and beyond, and really making clear to folks that even if you're not a doctor who is concerned with sexually transmitted infections and diseases, that you actually need to know about LGBTQ healthcare. Like it's a more holistic thing than just transmission of STIs. And so, yeah, I think that would be my biggest policy request or concern, would be to not only include that in medical school training, but also create easily accessible, low cost, no cost kind of professional development for existing practitioners to do a quick catch up.
I would like to add to that, and I hope I'm not stealing Lorraine's thunder here, but certainly policy directed to increase health literacy, number one. Also, policy sort of internal to the health department to where funds, resources, assets are used to empower LGBTQ communities, empower them to help organize them. They're very diverse. LGBT, they're very, very diverse. They're a very diverse community. But can we help pull people together? Can we help organize people? Can we empower them to demand what they need from the healthcare system? I like what Katie said, but I like the push and I like the pull, both. So push from the medical school side, so people come out, they're ready, and so forth, but pull from the community, so demand from the community for this.
So I'm going to hop on Katie's train and say we also need to add more. We need to add curriculum about treating tobacco use, the #1 killer, to medical schools as well, so that it's almost like in some settings, even though every clinician is supposed to ask every patient every time about their smoking status, it's almost like they're assuming someone else is doing it. And then with particularly patients that are maybe low socioeconomic status, they don't get seen by the doctor very much unless there's an emergency, smoking screening goes out the window kind of in those cases. But we really need to get back to prioritizing this epidemic that is ongoing. And with regard to policy things, one of the big things in my area is tobacco-free workplace policies. I mean, if you go, most places that we probably all go to send the message that tobacco use is not a normative behavior. i.e. tobacco use is not allowed in these settings because your use of tobacco hurts others around you that can't, get away from it if they chose to. But if you look at some healthcare settings, I want you to know we have healthcare settings in the United States, plenty of them in Texas, that allow smoking right outside the door to go in to see your doctor, that everyone is walking through on the way in and on the way out. And so I think the implementation of tobacco-free policies in most settings would be an important way to try to reduce tobacco use, broadly speaking. And of course, that has to be coupled with the availability of evidence-based care for tobacco cessation, right? And so kind of concomitant with this, like treatment professionals that I've worked with in substance abuse settings and mental health settings, they don't even know that there's a state quit line for tobacco use that anyone can access freely that provides free care. And if the treatment providers don't know that, the people that they're seeing don't know that. And so we're missing all these opportunities to use evidence-based interventions in the settings where we see people that use tobacco. And I think that that would be the next step I would like to see in the policy sphere for tobacco equity.
So I have a project on incentives to exercise through the YMCAs, which is actually funded by the National Cancer Institute, because obviously exercise is very important for cancer prevention. And, as many things that are behaviors. So how do we basically incentivize people to change behaviors? I think that is a key concern. This, however, needs to be put in the context of what was just said. And I like what my colleague said, because sometimes it's very difficult, right? If I remember when I was born and raised in Ecuador, I lived in Mexico, I lived in Ethiopia. Sometimes you want to exercise and you can't because there is not a park, there is not a sidewalk, there is not a field, a space to exercise, right? Not every country is as lucky as the US to have YMCAs all around, and not everybody has the money to pay, $50 for a YMCA membership. And so it is an issue of structure, it's an issue of the system. How do we change the system? How do we change the structure so that there is more access? And I think that is the key, right? How do we change the laws, and how do we make sure that there's things at the national level that make it, prevention and treatment more accessible to people? So it's I think, as John put it, is an issue of, yes, how do we incentivize demand, but the supply needs to be there as well. So we have to have both in a way, right? The carrot and the stick. And it is complex, but it is possible, right? So if you have a combination of those things, it is possible to get somewhere.
I was talking and you couldn't even hear me. Oh my goodness. You guys have no idea how often that happens to me on Zoom. But anywho, time flew by. That was our last question. Before I pass it back to Jayla, I want to say thank you guys again for coming to talk to us and sharing about what you guys do. Jayla.
Yes, thank you so much, India, and everyone. I wanted to give time to have people ask questions for our panel. It looks like we have 3 questions already. So I'll just kind of start up our first one, and I'll read it. If you feel comfortable and you would like to come off camera or mute and ask your own question, by all means, you are more than welcome to do that. But if not, I'll go ahead and read it. So we'll do the first one, which I think Zoom is fancy now and it shows you what the question is. So you all should see it as well as me. But if you could give any advice to people just entering the field of public health, cancer, or commercial tobacco prevention, what would it be? And is there anything you wish you would have learned or prioritized sooner?
Absolutely. Press for better and more specific surveillance information. Don't settle for 2 or 3 demographics, the usual suspects.
I think mine would be listen to the community, listen to the people, listen to the patient. And if you are doubting what they're saying, run it through your own kind of, do a bias check on yourself first before discarding anybody's reported symptoms or concerns, and try and come at it from a collaborative place of any problem can be solved, rather than this mountain is too big to climb.
Mm.
I was never taught how to do a randomized controlled trial when I studied economics, and I had to learn by reading the Lancet on my own. Let's just say it was uphill climb. Nowadays, I think they teach randomized controlled trials in economics school. It has changed, but all of that to say, get to do the best science you can as soon as you can, whatever the field is. Just get the tools to do the best possible rigorous science. If you really can establish cause and effect, then you have something, but most research cannot. And so, that's what distinguishes really good research from most research, which is actually very mediocre in my experience. And so, if you do RCTs, they have to be very, very well done so that you can really contribute to science. And if you cannot do RCTs for whatever reason, then make sure that you have tools to do causal inference with quasi-experimental or non-experimental design, so that you really can contribute to say something about, cause and effect.
And I think I would add to what Katie said, and say, collaborate with communities, but also co-create with communities. Because if you co-create interventions with communities, the communities have ownership in the intervention. And moreover, frankly, they better understand the needs that they have than anyone from the outside ever would. So involve the community or community representatives in every phase of the work that you do, from planning all the way through to disseminating information back into the communities in an effective way.
Can I say one more thing? I think it's really important, especially at the beginning of our careers, to recognize that just because we want to think that we are educated about something doesn't mean that we are. And by that, I mean, I'm a person who likes to think of myself as, on the right side of social justice issues. And so I want to be an advocate for everybody. And if I were a doctor or in a medical setting, I can imagine myself really saying, yes, absolutely, I will work with you to solve this problem. I understand what's happening. But I think that the danger there is that because I believe that, my heart is in the right place and I have the motivation, I think I still need to do a lot of learning and a lot of reading so that I can actually and listening so that I can actually care for that community or that person.
Yeah. Awesome. Thank you. I think we have one question, I think, for Lorraine. What are the tactics that the tobacco industry has used that we should look out for when we are organizing our communities and developing health programs? And if anyone else can answer or speak to that, I think that's okay as well.
I would recommend, there's a publication from the Truth Campaign that they put out some years ago now. And of course, now it's going to elude me. It's called, oh gosh, I'm going to remember it in a second and I'm going to put it in the chat. But it's like this very easy to read kind of executive summary with details about how the tobacco industry has made cigarettes more and more addictive over time. So I always recommend that to people to read so that you get an idea of what the tobacco industry has done, both to their product as well as the ways in which they market. Now, the question that you asked about like how to, what are these strategies? I'm going to tell you that it might depend on, tobacco industry has tons of money. They have tons of money to invest in understanding what might appeal to various marginalized and minoritized group. And trust me, they use information in those communities to make it work, whether it is selling loosies, which is illegal, which is just one or two cigarettes from an overall pack in a low socioeconomic Black neighborhood, to going to pride parades and supporting pride groups and that sort of thing, and giving out cigarettes. I mean, those are tactics that they've used previously. And unfortunately, there's a lot of connection between the tobacco industry and politics and lobbying. And that drives, I think, a little bit of our lack of being able to address the health equity issues that arise within our communities. So there's a range, and there are some really awesome books about this that I'm going to recommend to you in the chat if we have another question that we can go on to. And I recommend that you read that for kind of a starter understanding of how truly evil the tobacco industry is. Unfortunately, it's one of those, it's probably maybe one of the only industries that works really hard to kill the people that support it.
I think that can be generalized to the advice, that they gave during the Watergate trials, follow the money. So it's very important in public health also to look at, how is the money distributed? How does it flow? And, the example that I gave you of the treatment action campaign in the early 2000s is very important, because there was a lot of push for the pharmaceutical companies to reduce their pricing. And now we have what is called, differential pricing. So basically the same product can cost, like I said, $45 in sub-Saharan Africa, and it can be, orders of magnitude more expensive in the United States and in Europe, as this should be, because the ability to pay is very different in sub-Saharan Africa than it is in high-income countries. But what I wanted to mention is that is somewhat similar, perhaps after the tobacco companies, the pharmaceutical companies have the also probably the worst second bad rap. And so, however, there is reputations to be had, right? These companies also care about reputations, and they have charitable arms, and they have foundations, and they have public relations arms. And so sometimes it's important to be smart about that. And that's how many people have access initially in Africa for lower price, and in many low-income communities in the US and other high-income countries, through these charitable arms and through these PR campaigns, there is free product to be had, which is very important. But at the same time, you also have to push and lobby for reductions in prices, and just be smart about who gets what, and who are the shareholders, and who's responsive to whom. Very important lesson in public health HIV history, actually, going back to Katie's. I mean, this is just a historical fact that if you don't push, you don't get anything.
Thank you. And then we have one more question. I'm not going to read the beginning of the question, but I will feature it. But the gist of the question is basically to summarize, for those of us that are doing work in communities that align with our identities, it can be really easy to internalize that work. So in our research and our classrooms, how can we talk about these desperate outcomes while emphasizing all the wonderful things about queer identities, like community, resilience, etc.? I think that's a great question to kind of end on.
So this is one of my favorite things about my research, is that I can talk about all of these health disparities, and then I talk about how the LGBTQ communities have filled those holes for themselves, right? So in my first book, there was an amazing drag queen called Wanda Lust, who would come and go around the bathhouses and test for VD, and would offer people milk and cookies and put band-aids on their boo-boos and do all kinds of hilarious things. But as a result of that, the blood drawn proved to be really influential in creating a hepatitis B vaccine, and is now part of one of the longest running kind of AIDS medical databases that exists in the world. So I think thinking about how people respond. You know, I think pressure makes diamonds is kind of my response. So look for the diamonds. Talk about the pressure too, but also recognize that resilience is a beautiful and amazing thing. The fact that folks thrive and create tremendous culture despite these things is really important.
I would just underscore what Katie said. The reason we've moved ahead, certainly the reason we've moved ahead with HIV diagnosis, drugs, treatment, funding, Ryan White, et cetera, is because the LGBTQ community organized themselves, discovered that there were great strengths in numbers and also in the that they were discovering that they were on the right side of social justice issues and could stand up about that and put that right in other people's faces, making very justified and justifiable demands and so on and so forth. We would be no place without a riot that occurred in my hometown several decades ago. No place in this.
Great. Thank you. Thank you all. So I'm looking at the time. I'm like, oh, this always happens. We always get really into it. And then it's like, wait, no. But I think that we'll close that out. If anyone has any other thoughts, please feel free to put it in the chat. I just wanted to, before going on to announcements, thank everyone who came and participated in this, whether you attended, whether you were on the panel, whether you helped moderate it, whether you asked a question. I think this is a wonderful discussion. A few announcements before I will just rapid fire them off to you. Our student advisory committee put on this event. We are going to be having another student advisory committee this upcoming semester. So if you're interested in joining and being a part of the student advisory committee, we have an informational meeting on Tuesday, October 17th. If you know anyone that's interested, send them the link to register. You can go to the next slide. This event is a part of a larger event that we're doing, which is the Public Health Hackathon. So what we're trying to do is get our emerging leaders to think really critically about a public health equity issue of their that impacts them, whether that's local, regional, or national, and then propose a solution, whether that's a policy, program proposal, etc. And so those submissions are due on Monday, September 25th. The instructions on how to sign up are here. If you want more information, I'll also send it out in an email follow-up. And then if you want to stay engaged with CLLU, go ahead and sign up to participate by completing a participant profile. Or if you know anyone that this program might be of use to. I know one of the things that we talked about today was kind of educating our emerging leaders on a lot of these issues. And I know that this conversation is like one of the small pieces of conversations that we kind of need to be having across the public health board. So yeah, that is, I hate to end things so abruptly, but thank you all again for coming to the event, and hopefully we'll see you at the next one.
Thank you. Bye-bye.
Bye, everyone.
Thanks. Nice meeting everybody. Take care.
Thanks, everyone.